Colorectal NETs, different biology from small bowel tumors. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been wondering about colorectal neuroendocrine tumors, particularly how they differ from small bowel NETs, you're in the right place. I know hearing about any tumor can feel overwhelming, but today we're going to break down something important. Colorectal NETs are not all the same, and they're fundamentally different from their small bowel counterparts. Before we dive into the differences, let's establish what we're dealing with. Neuroendocrine tumors, or NETs, are unusual growths that develop from cells with both nerve-like and hormone-producing properties. When we talk about colorectal NETs, we're actually discussing a surprisingly diverse group of tumors affecting the cecum, colon, and rectum. Though grouped together anatomically because they all occur in the large intestine, these tumors behave quite differently depending on their exact location. Let's talk about the elephant in the room. Colonic NETs, particularly those in the main part of the colon excluding the rectum, are fundamentally more aggressive than rectal NETs and require formal cancer surgery with lymph node removal. If you're diagnosed with a NET in your colon, the median survival is approximately 14 months for metastatic disease, compared to over 20 years for rectal NETs. That's a dramatic difference. Why such variation? Colonic NETs are usually single, large, highly invasive tumors. They are often discovered at later stages with regional lymph node involvement. For tumors confined to the mucosa and less than 1 centimeter, lymph node metastasis occurs in only about 4% of cases, but for all other categories, rates jump to 14% or higher. Colonic NETs generally require formal oncologic surgery. That means surgical resection with regional lymphadenectomy, similar to what is done for adenocarcinoma. Here's some reassuring news. Rectal NETs are completely different. Most rectal NETs are small grade 1 tumors that can be effectively treated with endoscopic resection techniques, no major surgery required. The risk for lymph node or distant metastases after endoscopic removal of small rectal NETs less than 10 mm, grade 1, is very low. Research shows that for grade 1 rectal NETs, the incidence of lymph node metastases is only 5.2%, and distant metastases just 2.1%. For lesions 10 mm or less, endoscopic techniques like modified endoscopic mucosal resection, endoscopic submucosal dissection, or endoscopic full-thickness resection are recommended with low recurrence rates. The complete resection rate for ESD reaches 89% with less than 1% local recurrence. For rectal NETs between 10 to 20 mm, the decision becomes individualized based on full imaging and multidisciplinary team discussion. If you have an R1 resection of a small G1 tumor under 10 mm, studies from South Korea tracking thousands of patients show recurrence rates close to 0 at 2 years when adopting a watch-and-wait approach. However, for tumors with high-risk features, meaning G2 or G3 grade, or evidence of lymphovascular invasion, attempting re-resection to achieve R0 status becomes more important. Now let's talk about the cellular biology. Colorectal NETs, particularly rectal NETs, often originate from L cells. What does this mean? L cells are specialized hormone-producing cells that are often negative or only focally positive for chromogranin A, a standard marker we use to identify neuroendocrine tumors, but they're positive for L cell hormones like peptide YY. This L cell immunophenotype has been associated with more aggressive clinical behavior in rectal NETs. The practical implication is that colorectal NETs generally express lower levels of somatostatin receptors compared to small bowel NETs. Small intestinal NETs frequently express high levels of somatostatin receptor type 2, making them excellent candidates for somatostatin analog therapy and peptide receptor radionuclide therapy. For colorectal NETs, particularly hindgut tumors from the left colon and rectum, somatostatin receptor expression is variable and often lower. The metastatic behavior differs significantly between colorectal and small bowel NETs. While small intestinal NETs commonly metastasize to mesenteric lymph nodes and liver with characteristic mesenteric fibrosis, colorectal NETs show different patterns. Colonic NETs present with regional lymph node involvement more commonly at diagnosis. For rectal NETs larger than 2 centimeters, recurrences are typically described in the lateral pelvic compartment or as liver metastases. Here's something that might surprise you. The genetic makeup of colorectal NETs is fundamentally different from small bowel NETs. None of the abnormalities described in allele NETs, such as chromosome 18 loss or CDKN1B mutations, found in 50 to 78% and 10% of small bowel NETs respectively, have been reported in colonic NETs. This tells us these are genuinely different diseases at the molecular level, not just variations of the same condition. So here's your bottom line. Let's talk about the 3 categories of action you can take. Advocate for precise diagnosis. Ensure your medical team has clearly identified whether your NET is colonic, cecal, or rectal. Location determines everything from prognosis to treatment strategy. Given the complexity and relative rarity of NETs, discussion at an experienced multidisciplinary tumor board is strongly recommended. For colonic NETs, ask, What type of oncological resection is recommended? And what are the risks and benefits? For rectal nets under 10 mm, ask, am I a candidate for endoscopic resection? For rectal nets 10 to 20 mm, ask, what does full imaging and multidisciplinary review recommend for my specific case? Ask, has my tumor been tested for somatostatin receptor expression? And what does this mean for my treatment options? Ask your doctor, what is the risk of lymph node involvement based on my tumor size, grade, and location? This is crucial information that helps determine the appropriate treatment approach and provides important prognostic information for your specific case. Immediate surgical consultation if you have a colonic net of any size, or a rectal net larger than 20 mm, or any net with confirmed lymph node involvement on imaging. Endoscopic expertise for rectal nets under 20 mm, where en bloc resection with clear margins is the goal. Ask about modified EMR, ESD, or EFTR techniques. Medical oncology with net specialization for metastatic disease, particularly if somatostatin receptor positive on PET scan. Recovery timelines vary. Small rectal nets removed endoscopically typically require minimal recovery, from days to weeks, while formal surgical resection requires standard postoperative recovery, 4 to 6 weeks for full recovery. Your individual recovery will depend on the specific procedure performed and your overall health status. Let me quickly recap. Colorectal nets are fundamentally different from small bowel tumors based on their location, with colonic nets requiring aggressive surgical management, while most rectal nets can be treated with endoscopic techniques. Your next step: ensure your exact diagnosis specifies tumor location, size, and grade. Then seek evaluation by a multidisciplinary team with net expertise. I've outlined several reputable resources here that you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.